I'm Philip Howard. My real job is I'm a consultant pharmacist for antimicrobials at the Leeds teaching hospitals, 3 or 4 days a week. And 1 day a week, I work for NHS Improvement as a project lead for antimicrobial resistance healthcare-acquired infections. And that's a hat I'm wearing today. But when I come and talk to you and ask you lots of difficult questions and you tell me I don't know what it's like working in a hospital and all the problems, yes I do, because that's my proper job. So you name the excuse, I've got the answer. Okay. So this is a workshop. Workshops are actually two-way things. So they're not just a seminar where you sit here and I just talk you for 3/4 of an hour. This is about you sharing your ideas all around the serious infection CQUIN. Because I'm a great believer in that we shouldn't reinvent the wheel and all spend lots of time doing things. We should actually take the best ideas with everybody. And I think this is how we're actually going to probably tackle this sort of CQUIN successfully. So I've put some aims and objectives here. So the aim of the workshop, share best practice, how we're going to achieve the serious infection CQUIN, and hopefully by the end of the session, we should be able to describe the rationale for the CQUIN, because some of you might think, I've no idea, we're actually having part of our budget swiped off of us to achieve the unachievable. Certainly we'll go through the elements of the CQUIN, and we'll go through and try and understand how we're going to achieve it and share some ideas. And then hopefully at the end of it you'll be able to share strategies when you go back to base on how we'll actually improve the care of patients with sepsis, but at the same time not worsening antimicrobial resistance or hopefully doing the patient any harm. And funny enough, I will be talking about harm after this session when we talk about C. diff. So you may not be aware that we actually have national clinical improvement schemes out there. We shouldn't call them incentives, though they probably are incentive schemes to try and get you to the right things. And there's two that exist. There's one for primary care and one for hospitals. So the quality premium for primary care is about rewarding CCGs for improving the services they actually commission, and hopefully to improve patient health outcome and reduce the inequalities, and ideally improve access to the services. And they get paid a certain amount per patient, and it's worth about £40 million a year. But CCGs don't necessarily get all this money. They had to get all of the elements that make up the sequence, the QP actually to get it, and quite often they don't. For hospitals, so CQUIN's is commissioning for quality and innovation, and this is all about, again, clinical quality improvements and driving transformational change. And I can't stress this enough. Everyone sees CQUINs purely as, if we don't do what we're told, we're not going to get our money. But it's about changing pathways to actually improve the care of patients. And people have to really understand that's the real thing that we're trying to do, not just tick a box to get the money. It's about true change. And again, it's about reducing inequalities and improving the outcomes that are achieved. And that's actually paid in year. So you have to do give various bits of information to your commissioners to get the money. Okay, so last year we actually had two, which were one for the year 2 of the sepsis CQUIN, and we had the first year of the antimicrobial resistance CQUIN. And in the sepsis CQUIN, this was all about, and Ron has actually updated the data. It's not 11,000 preventable deaths out of 32,000 deaths from sepsis. It's now up to 14,000 preventable deaths in there. And that's a real problem. And Ron's already told you this morning about some of the problems who people who are the survivors of sepsis. Actually, they don't go back to living life how they were before. It affects them in many, many ways. The reason we've ended up, and I'll talk about the next one, is a merged CQUIN, is you can only have a national CQUIN for 2 years. And of course, we've already had 2 years worth of sepsis CQUIN, and I'll share with you some data on the next slide, why we've kept it on the agenda. And then we've had the antimicrobial resistance CQUIN, and this was about trying to reduce the total amount of antibiotics And the reason for that, we are still one of the highest users of antibiotics in Europe. So we've improved 3 countries, we've moved down overall, but in hospitals, we're still the second highest consumer of antibiotics per head of population in Europe. So we're not in a particularly good place. We've got a load of work to do there. And also reducing broad spectrum antibiotics, and then I'll talk to you a bit about the day 3 review, because this is about how the Start, Smart and Focus all fits together. Hopefully this is not new to you. So Start, Smart and Focus has been something very much within the hospital arena. In primary care, it's about often, if you've got someone suspected of sepsis, you'll generally send them straight into the sort of the hospital, either blue light or get them to have a carer to take them there sort of fairly quickly. You don't tend to do that focus because actually, if you end up giving somebody a course of antibiotics, they complete the course of antibiotics, hopefully, in primary care. In the hospital environment, it's around starting smart for the 6 patients, making sure we send off all the right tests, and then within those 3 days, because we're still working with diagnostic tests that are still in the dark ages, then hopefully we'll see how the patients have got on, review how they are, and hopefully either stop the antibiotics if they're not needed, switch them to oral, and I'll tell you some of the advantages in that, or send them to a more narrow spectrum antibiotic, and we log the decisions. So this is how the Start Smart, the sepsis element, and the then Focus, which is about reducing antimicrobial resistance, fit together. You've seen a slide like this already on some of the talks this morning. So in primary care, and again, it's not 90 million, it's 40 million, we'd seen a huge reduction in total antibiotic reduction in the first year, a 7% reduction, that's 2.5 million less prescriptions, and a 13% reduction in broad spectrum antibiotics. And in the following year, we didn't see any change, but which meant we still had 2.5 million less prescriptions because we stayed at that same level, but we further decreased broad spectrum antibiotics. And I'll tell you some sequelae in a while. And then in hospitals, we ended up having the sepsis screening in the first year for those presenting in the emergency department, a 4.5% reduction in mortality, which is really good news for those sort of patients on there. But we saw a 20% rise in the use of IV antibiotics in the emergency department, which is a bit of a worry on there. Then in 2016, we actually saw a continuation of the sepsis CQUIN rolled out to inpatients and included a day 3 review because we saw that rise in IV antibiotics in the emergency department. We thought that was driving antibiotic consumption. And then for the hospitals, we had the CQUIN, which was aiming to have a 1% reduction of defined daily doses. Defined daily dose is a WHO assigned value for what the average dose of an antibiotic you would use in a day. So if you use cefuroxime 1.5 grams 3 times a day for some of your patients and cefuroxime 750 milligrams 3 times a day for some of your patients, the WHO defined daily dose is 3 grams, so it somewhere sits in the middle. That's how they come up with the value. So it's in grams. So it allows you to compare different lots of antibiotics. Otherwise, it's quite difficult. I mean, it was trying to reduce total antibiotics by 1%, but as we kept on growing our usage over a 4-year period, we've actually increased our antibiotic use by 12% over 4 years. So our real target ended up with a 3% reduction. And we didn't achieve it. Overall, we saw just over 0.5% reduction. For Carbapenems, so in theory our last line antibiotics, we'd seen a 36% increase in use per admission over a 4-year period. And we're starting to see more carbapenem resistant gram negatives, certainly in the northwest. And so our target there was 1.3% reduction, and we actually received an 8% decrease in carbapenems, which is staggering. So it's amazing what we can do when we put our minds to it. And then for Penicillin tazobactam, because we told everyone when the C. diff was a real problem, 2009, the guidance came out, said stop using cephalosporins, stop using fluoroquinolones, brackets ciprofloxacin, stop using coamoxiclav, which everyone clearly forgot about because they continued using it like in gay abandon, and stop using clindamycin. they switched to something else. And what they switched to was everybody got piperacillin tazobactam, and that was a big problem. And we saw a 55% increase in use over a 4-year period. And at the same time, we drove resistance in Klebsiella up by 36% and E. coli resistance by 31%. So overuse was driving resistance. And our target was a 14% reduction per admission, and we failed to achieve the target, but we got an 8% reduction, which again I think is quite good news. And then we asked for day 3 review of antibiotics, documented the notes, and 98% actually achieved it. There was a huge unintended consequence of not using so much broad spectrum antibiotics, and that was a 9% reduction in C. diff numbers, and I'll talk about this in the session afterwards. So that was an unintended consequence, which was good news.
Sorry, Bill, when you say we, do you mean England?
Yes, we. If anyone's from Scotland, anyone from Scotland? It's a lovely place. That is in England, so we only have the England figures. So when I say we, I mean we in England.
I didn't know if it was your trust or...
No, we in England. So I'm wearing my We England hat today. So if we focus on appropriate antibiotic prescribing on the sepsis CQUIN, then we've got, again, I mentioned about the preventable sort of deaths on there, which was all about sort of timely treatment, and the day 3 review, because we'd seen this increase on there. But the important thing for this is there is good evidence to show that timely antibiotics is linked to decreased mortality and shorter lengths of stays for the survivors. So that fits into the whole time to referrals for various things, waiting times in A&E and all those other bits and pieces. We can get patients out quicker. So this is the end of year data for the sepsis CQUIN, and you can see for last year, you can see the screening rate got up to 86% in ED, rapid antibiotics and a review. Still work to do, got up to 61% by the end of the year. And then for inpatients, the screening increased up to 71%. So still some work to do on there. And then rapid antibiotics and day 3 review got up to 3/4, 75%. So we have made some progress, and this is why it's rolling over to be a CQUIN again, because actually we're not at that 90+% that we hope to do. So that's why they've been merged together, all of these bits and pieces. The graph, which I've drawn all over at the bottom, shows the variation that exists across the country, and you can see some trusts achieved 100% of patients in ED who got their antibiotics in a timely manner and a review, and going down to sort of some trusts who were less than 20%. So there's still enormous variation that exists here, and this is some of the variation we're trying to sort of minimise. We also asked part of the CQUIN to people if they would submit voluntary data, and so I've done some bit of work looking at this voluntary data about day 3 review, and so what we're trying to look at is the percentage of patients who started on an IV antibiotic for best guess or empiric therapy who actually switched after day 3 review. The best in class, so the lowest prescribers of antibiotics in the whole of Europe, in primary care and in hospitals, is the Netherlands. Anyone from the Netherlands? Anyone worked in the Netherlands? That's a shame. You could have shared with some of your magic ideas when we do some questions later. They only continue about 1/3 of their patients on there. We can continue 2/3 of our patient on the same IV antibiotics. And there are some benefits of moving away from the same IV antibiotic. And I'm just doing a bit of work at the moment for trust boards selling all the benefits on this. So don't be surprised if you see a variation of this coming across your desks at some stage. So we know that C. diff's related long-course to broad spectrum antibiotics. Mark Wilcox has just published some paper this year showing it costs £6,000 per patient, and that's just the first incidence of C. diff on there, and 15 extra days lengths of stay. I won't go into the detail of what happens to relapses. We know mortality is approximately 1 in 5 at 28 days, but as much as 1 in 3 at 90 days. So this is some of the work we did about the real-world evaluation of fidaxomicin. We realised it's a bit like a fractured hip in the very elderly. You rapidly get that sort of decline on there. For Staph aureus bacteremias, 15% are device-related. You get your Venflon out. You're not going to get a an infection related to that. And if you look at some of the work that's been done in this country, where they've had microbiologists, antimicrobial pharmacists, going to look at patients who've already had reviewed by their clinical teams, almost a quarter of those patients could be either have their antibiotics stopped or switched. And this potentially can save up to 6 days length of stay per patient. And if you switch them to oral, it saves £32 on average. If you stop it, £36. Have any of you come across the Lord Carter's model hospital metrics? Anybody heard of model? Put your hands up if you've heard of model hospitals. So model hospitals is a bit of work that Lord Carter's been doing, trying to reduce variation between all hospitals, and it's looking at absolutely everything. It's looking how much you pay for things, staffing levels in theatres and everything else, trying to identify variation so we can get the best use of the lack of money which we've probably got in the NHS. We know it's unaffordable at the moment, so it's trying to get the most efficient use of it, and it's called the model hospital, and there are dashboards. So your homework, go and Google model hospital dashboards, and you can freely access this data, and you can look at absolutely everything. And it's based upon the model hospital as a 500-bedded hospital. And so what I've done is I've translated some of these things in actually doing a robust day 3 review of empiric IV antibiotics can save the following. So probably 80 bed days each day by switching in a 500-bedded hospital, 70 minutes less nursing time per ward, or 3.5 nursing shifts per ward. That's by orals are much quicker to give than IVs. And that equates to probably just under £250,000 per year on antibiotics, looking in that. And that can be achieved by approximately 1 session, and they did the work with microbiologist per ward, and this was in Holland. And if you multiply that up for a 500-bedded hospital for 2 extra staff, this is what you can achieve by sort of doing this. And this is one of the things we're going to try and drive, say, invest to save overall on here.
Can I ask a question? Do we know who prepares the IVs in the Netherlands?
I think they just do it on the ward. I'm not clear.
It's doctors, we think.
I don't know. I presume it was nurses. The healthcare system in the Netherlands is very similar to ours, as far as I'm led to believe by my colleagues. And then the final thing, OPAT. I don't know if you know. So OPAT is outpatient or home IV antibiotics. Does anyone have their trusts or their community run an OPAT service? Hands up. Hands up if you don't. Hands up if you've not moved your arms. Just testing. And certainly some of the data on there shows you can almost save about 2,000 bed days per trust for adults and about 500 for children. So there are real opportunities to be there. And if ever you've read the 5-year forward view, one of the objectives in the 5-year forward view is decreasing total beds by about 2,000 to 3,000 overall. And this could be one of the ways we could help to deliver it by treating patients closer to their home. So what's happening this year? So this year there are, in terms of incentives, you've already heard this morning during your sessions about reducing gram-negative bloodstream infections, and there were some fascinating talks there. And then we've merged the antimicrobial resistant septic schemes into reducing the impact of serious infections into 4 elements. So the first element is about the timely identification, treatment of sepsis in ED and acute inpatient settings. Second part is about the timely treatment of sepsis in ED and acute inpatient settings. And the difference here is it's changed to 60 minutes from diagnosis of sepsis, which is a pretty big change. And part of the reason for that was a lot of people were just giving an antibiotic to tick the box. And what we wanted to do was change the pathway so you were actually getting people looked at in a timely manner, and actually it wasn't just ticking a box, it's about changing the pathway. 2C was about reviewing antibiotic prescriptions within the first 3 days, who were still inpatient 72 hours, and I'll talk about that a bit more, because instead of last year it just said carry on antibiotics would do, if you carried on the same antibiotics, you would have to justify why you were continuing them. You had to record whether you'd sent blood cultures and actually whether positive or negative, and then the outcome of your day 3 review. And that will be feeding into the Carter Model Hospital dashboard as we collect that data. So this is quite important for identifying variation in there. And then the final bit was about reduction in antibiotic usage. And depending how you'd performed in 2016, January to December, and you might ask why it wasn't a financial year. And the reason it wasn't a financial year was you had to have something in place before the start of the year. And people didn't have to submit their data for at least a month after the quarter that just ended. So that's why it was 2016 and not the financial year. So we had either a 1 or 2% reduction in total antibiotics, carbapenems, or piperacillin tazobactam. Who knows what their target is for their hospital? Hands up who's got mainly 1%. A few of you. Hands up who's got 2%. If I had 3 arms, I'd put 3 arms up. So we got on there. So it's going to be a challenge. Who's ever looked at the Public Health England antimicrobial resistance fingertips data? Hands up. Hands up who hasn't. Hands up who's not put their hand up. Just testing you again. So this is a central portal for covers antibiotic prescribing, antibiotic resistance, antimicrobial stewardship on there, healthcare acquired infections. It's got all the data in a single place. You can either look by acute trust, you can look by CCG, or you can look at GP level. It is the first data that's publicly available anywhere in the world, and it's got everything on there.
GP level data on there when I looked last week, the GP level data didn't come on, but the CCG and the trust data did come on.
So there is some data on there, but only for certain elements of it, which I haven't put on this slide. So you can look at antibiotic prescribing, GP level. And I would say go and have a look at it, because the reason we've developed this is allow you to look at your peers. So instead of going, oh, if you work in Leeds, I look nothing like Huddersfield, but you could pay yourself to Sheffield or to Newcastle, who might have something similar if you're a hospital. And it's about choosing your peers, seeing how you get on, and again, trying to help drive improvement. And so I regularly talk to Sheffield and go, how come you're so good and we look so rubbish in Leeds? And they go, oh, because we've engaged with our prescribers and everything else. So it's about having conversations to learn from everybody else. Okay, so what we're going to do now is we're actually going to spend the rest of the time going through some of the elements, and you're going to share with me what you're doing. And then I've got a few examples to try and sort of help you. So don't be shy, because this needs about you just say, I'm Fred Bloggs from wherever, and just to share some examples. And the last time we did this down in London, we got some brilliant examples from lots of different places. Lynn has got a microphone. And so just wave, and Lynn will come and ask you. So I'm going to go through a number of sort of questions on here, which I've sort of gone through already, and I'm up to you for sharing sort of some of your examples sort of going through there. Are you all on board to do that? Then I'll tell you a tennis score after we've done it. Okay, so the first question then. Who's managing to achieve greater than 90% for their screening for sepsis in ED or inpatients? And how have you done it? Lady over here. Just say your name, where you're from, because I'm going to make notes.
So, I am Jane Flynn and I'm a sepsis nurse. Gateshead Foundation Trust.
Where?
Gateshead Foundation Trust.
Gateshead?
Yeah. So I've done it through live audit. So we have Vital Pack, not in ED. We have it on the inpatient. So in the inpatient setting, I run off a list from Vital Pack, who's triggering high news. I go and visit the wards. Hopefully, if they need a tool, it's completing in the notes. If it's not, then I always visit the wards when it's a quieter time on the wards, if there is ever such a time, in the afternoons, and then I'll use it as a teaching opportunity to say, look, this is what this should have happened, the tool, and I go through the bundle and everything with them. And so achieving it really through a live audit. But in ED we do something slightly different because we don't have electronic observation. We don't have vital pack in ED. So what we've created in ED is an incentive scheme for the staff to have a star award on the screening tool, and every month we'll pull off somebody who's done the most screens, and so that seems to be, and give them a little cream tea or something for the department. So we do things like that, but the way to go is electronic.
Okay,
You've got to get electronic.
So
unless you've got a big team to do the footfall, because I look on average at 150 patients a month to pull off me 50 for the CQUIN, to then get probably about 2 to 5 truly septic patients, then they have their review.
okay, that's brilliant. I love the sound of the Star Award, if you can't quite get there. Who has e-systems to capture this? Hands up. We have in ED. Hands up in ED if you have electronic system to try and capture it. A few. Hands up if you don't. Rest of you have no arms. Okay.
And the one of the generic rules doesn't it's not electronic capturing sepsis, but I know in ED we introduced sepsis SIPs, so they assess that, so anything that triggers those and then start.
That's like the paper.
Yeah, that's the paper copy.
Okay. Who has e-news on there? Does it work?
Yeah, it started to work. So we've got we've just had a rollout of all our EOBs, so all the EOBs have gone live, and then we've just done a rollout of iPads across clinical areas to look at, in essence, the safer care bundle, but also to underpin some of the work in relation to the sepsis CQUIN.
Where are you from?
I'm from Hull and East Yorkshire Hospitals. I'm the lead nurse for the Department of Infection. So the sepsis, I'd say the sepsis team is one individual. I manage that individual. Achieving the 90%, over 90% reduction in ED is exactly the same. Very much an incentive scheme through all the ED staff, because often they get increasing pressures from other areas regarding throughput, 4-hour waits, etc. So then to be bashed again because of sepsis. So it's very much an incentive. So we've almost like done a team of the week or a team of the month, and we've done a giant Miller's cookie with the percentage that they've achieved. I'm saying I have not done any of it. It's the sepsis, my sepsis specialist nurse that's done it. Really. The other thing that's assisted us is that we've got an infectious diseases consultant underpinning from a clinical point of view. So we've got the medical staff and the nursing staff involved from that perspective. So it's a bit of a two-pronged attack, really. So from incentives, it's just being purely incentives. It soon became apparent to then be able to do it from an inpatient point of view was going to be extremely difficult for just one individual in a 1,300-bedded trust on 2 separate sites. So we've just successfully got a business case passed to get a second sepsis specialist nurse, and she starts on the 9th of August.
So out of the two, give me these really good suggestions. Do you think you've successfully managed to change hearts and minds and the pathway?
No, it needs, I don't know about, it just constantly needs that drip feeding.
Yeah.
Constant drip feeding.
If I go on annual leave, well, I haven't been on annual leave, but I know the figures are going to drop when I'm on annual leave, because it needs that constant prompt. I do a lot of ward-based teaching, because they'll not come off the wards for 2 hours and go and do your teaching. But
So how do you think we can change that message through to the staff that's saying screening is looking at patient survival or decreased morbidity?
You put the screening tool electronic and you don't let them progress through vital packs. So they do their odds and you get a high trigger, and then it'll come up on vital pack, consider sepsis screening, and then it stops. But then what should happen is it shouldn't let you progress any further until somebody has done the screening tool and done that assessment.
Okay. So you may or may not be aware, have any of you received a Freedom of Information request that's come through? Yes, interesting. And Panorama, I think they're due to make a programme about it very soon. So it's asking some of the learning about what are we doing about people who aren't hitting the screening and the timely sort of treatment.
But they're asking for a lot of information that we didn't keep. We simply just don't have it.
Yeah. So interestingly, some of this data is going to start being, I've got agreement from Sir Bruce Keogh to actually have this on the AMR fingertip portal. So it'll be public available to see how you're performing as an organisation in terms of your screening and everything else like that. And so there will be questions asked around that. Okay, second bit then. So, timely antibiotics within 60 minutes from diagnosis. How are you getting on? Who's achieving this? Who's achieving in the 90-odd%? Anybody? 86-ish, good. Anybody else who's not from either Hull or from Gateshead? What are your big problems? Do you know what your rate is?
Knowing when the clock starts, I think, is one.
Okay, so the clock was relatively easy in the old way because it was when you you were basically clocked in for the old element on it. This one is from sort of diagnosis. So, i.e., when a doctor, so if we're an inpatient, we've passed that news threshold, we've called a doctor to come and see the patient, so the doctor's seen the patient, that's when the clock sort of starts.
Well, the nurses will say that it's the doctor's not prescribing more, and the doctors will say that it's the nurses not putting it up in a timely manner. With tit for tat, really. But both of them happen, which is why you get.
So how many trusts actually have it brought in an element where the doctor, if he prescribes it, gives it? I've heard that feedback from other sessions we've done. Anybody? Or they're there whilst they're trying to get fluids and everything else up on the patient, ensuring that the nurse who's working with them is actually going away and getting the antibiotic put in. Anybody? So what are your barriers then? Because there's only a couple of people who are doing it. What are your barriers? Lack of ownership? Who do you think does?
Communication between the two healthcare disciplines.
So do you share your results publicly? How do you communicate how you're performing? Is your organisation aware of how you're performing? So I know the two good places do. What about the rest of you? Do you know what your current performance is?
I don't think in our trust the data's not openly shared. I think it's public so people know it. Probably some A&E people and sepsis leads as a consultant, but.
So do you think it'd be helpful to actually have it on the AMR fingertips portal and then your commissioners asking questions? Yeah? Okay. So so that's just the blue dots again, and that very huge broad range on how well people are doing. University Hospital in Birmingham actually have, and because they've got electronic prescribing on there, is the matron for each of the areas, or whoever's carrying the bleep, is continually paged for any antibiotic which is more than stat antibiotic more than 15 minutes late. And they've said that's made a huge change to actually getting antibiotics given in a more of a timely sort of manner, because she will end up going, this pager keeps going off, why haven't we given the antibiotic? How many of you here actually have e-prescribing systems? Yeah? So maybe one of the things you might consider is actually how can you link some of those things together, and that might be one of the useful bits. And then we've discussed doctors to give the first dose of antibiotics. Okay, let's pick up number 3. Give me eye. We've got 20 minutes, haven't we?
Got about, 5-10 minutes.
5 or 10 minutes? You lied.
Yeah.
14:25 we started.
3 o'clock nearly.
14:25. You see, did you hear me ask her if it was 3/4 of an hour?
So it's 10 past 3, so
Yeah.
you've got 10 minutes.
Okay. Okay. What about reducing total antibiotic consumption? Who's managed to achieve that? Who's going to achieve the 1 or 2%? Yep. Where are you from?
South Tees in Middlesbrough.
And what have you done?
We've done lots of different interventions over the last 18 months, which I think we're now seeing the benefit of. It was a big drive at the beginning, but we're starting to reap the benefits of that. The first thing we did was change the prescription chart. We've got an antibiotic section, which I don't think is unique. I think a lot of trusts have done that across the country. That was a big change for us. So once you get to the 72 hours, you have to re-prescribe the antibiotic if you want it to carry on. We've done a lot of education around this, and we're going to be one of the trusts that are going to be part of the pilot for the ARC programme.
So the ARC programme, just to tell all of you, the ARC programme is an NIHR-funded antimicrobial stewardship grant, which is looking at what interventions can actually improve antibiotic prescribing.
So we've started the conversation with our junior doctors and doctors in training around ARC, and I think that message is filtering through quite significantly, so we're seeing benefits of that early on before we even start, which will not be till September. We have antibiotic ward rounds. Our antibiotic pharmacist does ARED audits on a monthly basis right across both of our acute hospital sites, and that information is presented through our infection prevention action group, as well as our antibiotic guardianship and stewardship monthly meeting as well. So that information filters back down to the medical directors within each of our clinical centres, and they take the responsibility for then cascading that back through to their own teams. So it's a multi-pronged approach, and it's just continuously drip feeding that information and the performance of that area.
Okay, so it sounds like you've got all the key elements of an antimicrobial stewardship programme in place. There's something like senior leadership, I think, in there, audit and feedback in a timely sort of manner sort of on there. Okay, that sounds pretty good. So Southampton have done something similar on here. They won one of the Antibiotic Guardian Awards. They had a staff engagement exercise through day 3 reviews. They changed the duration of oral antibiotics. They put a flag. They had a doctor's work list sort of software which they use, which flagged up patients on antibiotics and those who'd been on for more than 72 hours and needed a review. They did some audits like Middlesbrough, and they ended up with having an electronic solution to define, because they just brought in electronic prescribing, who were on carbapenems and IV antibiotics for greater than 48 hours, and they were then sort of followed up. And they achieved that 1.4% reduction in total antibiotics, but more interestingly was the enormous reductions in piptazo consumption and carbapenem consumptions compared to the previous sort of year. And that was fairly sort of staggering. And that was by whole organisation engagement, a bit like we've just heard described sort of in Middlesbrough. The other bit you might want to look at, and I won't go through all these, but penicillin allergy labels. Having a penicillin allergy label isn't good for you. And generally, if you have a label, you end up moving from one antibiotic to lots of antibiotics, which increases your overall sort of consumption sort of on there. And it's linked to lots of problems with resistance and mortality. And then, a bit like other places, people have come up with antibiotic-specific prescriptions. This happens to be an example from Leeds that builds in a daily review code on there. And some people have used procalcitonin, which is a blood test that tells the difference between, this is in respiratory infections or sepsis, between things which are probably viral in origin or bacterial in origin, but you get almost an instant sort of test. And if you see the sort of the element on here, which about the impact on antibiotic exposure or duration, depending where you are, there's some fairly sort of big sort of impacts. Now, NICE did review this, and they said, actually, we can't recommend it for routine rollout. However, they did say, anyone using it, please make sure you feed it into some of the standard bits. So if you are using it, feed it into the CASPR registry, and they're collecting data at the moment. Okay, what about carbapenems? Who's meeting their carbapenem element? And I will say we saw an 8% reduction last year, and just because we've had a piptazo shortage is not an excuse to think we're not going to get the CQUIN, because 1/3 of trusts are still making an active effort and achieving it. 2/3 aren't. The CQUIN is not going to be suspended. Okay? Have you just pinning all your hopes on that? So, just to warn you, I've had a telecon this morning already. So, not yet anyway. Okay. Who's
one of the downsides to the world shortage of piptazo, so that we start to use an alternative regimen, but we are finding some of the antibiotics and drug regimens are now in short supply. So Penicillin, for example, is struggling to get hold of. Penicillin would like to get hold of.
Okay, so I'll show you some examples. So I was involved in some of the guidance pulled together, and one of the things that was said by RHI, which is the Government Advisory Committee, was carbapenems are recommended in some settings should not be seen as a default alternative to piptazo. And the whole thing is about doing the sort of the day 3 review on there. And we had seen this reduction, but a sharp rise more in the last sort of quarter. We didn't see a rise in the first 2 months. So when I spoke to The Guardian last weekend, we didn't have the data because it wasn't ready at the time. We'd actually still seen a decrease in the first 2 months. But June's data suddenly seeing a bit more of a sharper sort of rise on there. And certainly people are using sort of other options such as Trianam, again, short supply, fosfomycin, pivamcilinam, temacillin, things like that as an alternative sort of in there. And then in the West Hertfordshire hospitals, they've started doing daily meropenem sort of ward rounds, and they've shown some pretty staggering sort of impact. So anyone who started on meropenem, they're actually visited and reviewed to see if they could be moved onto sort of something else, and that's something they've successfully done. Okay, what about piptazo? We could say we're all going to achieve the piptazo CQUIN, because currently we're all running at about 70% reduction, sort of on there. What I will say to you is, I'll tell you what other people have done, is some people have switched to other agents such as temacillin. We've done it in Leeds quite successfully, and they've not seen an increase in resistance rates in bloodstream infections for either E. coli or Klebsiella quite successfully. And other places such as the Royal Free, and this comes from an ESPOR report, of saying actually instead of using piptazo, we know the resistance rates have been steadily sort of increasing. Let's use something like coamoxiclav or a cephalosporin with an aminoglycoside. And I don't know if you can quite see at the bottom, it shows the overlap as quite a useful sort of cover. And one of the places that has done this is Royal Free Hospital. So they've switched away from piptazo for most of their protocols, and they've shown a 40% reduction in their piptazo, and they've started using coamoxiclav and amikacin, funnily enough, which has driven some of the shortages of amikacin nationally sort of on there. So there are different ways of looking at it, and I do think we have to be a little more sort of broader than just saying let's replace one agent, piptazo, because it's got Pseudomonas cover, to another anti-pseudomonal agent, because we don't always need it, especially in some of these community-acquired infections. Okay, so day 3 review. Has anyone made any really good impact on day 3 review? Yep. For the same reason. Okay, and that's the same as the Southampton element at the moment on there. And then the final thing, so we've tried to come up with an e-form. We've got 2 minutes. And in Leeds, we're just about to start piloting this, and it's built from some of the work that was done up in Dundee and sort of elsewhere. And then we've tried to come up with a very simple IV to oral switch, mnemonic. So previously it was A, B, C, D, and nobody could remember what the A's and the B's and the C's came up. But I got a fab pharmacist called Louise, who's just joined us, and she said, we had a game, said, let's think of something really good. She came and said, I've got it, it's aced. Apyrexyl, clinically improving, eating, and not deep-seated. And that was the way she came up. And we came up with the little labels that can be stuck in the notes or places like that. And on the ward rounds, it's a case of doing the oral switch by just writing aced in there and somebody asking those sort of questions. And it was a simple thing on trying to sort of move forward. So those simple ideas might just actually help you, and it will meet the things in the CQUIN.
So even if they write that or they put that sticker in, even
if they tick the bits,
if they stay with IV, it shows they thought about it.
Yeah, and that's all it needs to be. You've actually clearly gone through. And I have a view that if a patient's on IV antibiotic and eating, 2 things should happen. 1, either switch to oral, or 2, considered for OPAT therapy. Simple in my mind. It's nothing sort of deep-seated there. I know the independent hospitals can talk to me later about they're not allowed to keep patients in hospital unless they're on IVs, but for the NHS elements, it's slightly different. And this is just the audits from Southampton. How do we do in my trust? Well, we were a bit lucky that we didn't have to do much work in total in Carbapenems, but we did reduce pip/tazo by a reasonable amount by using Penicillin plus amoxicillin for HAP, procalcitonin that's come in, which has made some huge impacts, but we've still got work to do on the day 3s. So, right on time. In summary then, I think to meet the serious infection tweaking, we've got to come up with better systems to actually have better prescribing and for de-escalation. We've got to review our guidelines that contain the broad spectrum agents and make sure they're followed through audit and feedback. It's all about little and often audit, so quality improvement, not one-off ones. Get your sepsis and stewardship teams to work together. Make sure your systems for protected or restricted antibiotics work well. Monitor and benchmark against your true peers, sort of out there. Regular and varied communications on your progress, local education and training at ward level, and I think strong and effective multidisciplinary sort of leadership. And if you do have any ideas, send them to me, because we want to share them. And I've certainly got some of the good stuff from Gateshead, Hull, and from Middlesbrough. So if you stay behind afterwards and give me your email addresses, that'd be really helpful. And share it. And I'm a great believer in borrow or steal, adapt, and then share it. So don't reinvent the wheel. So take any bits you got here and do it. Because ultimately, this is all about improving use of antibiotics, because we don't have any antibiotics at work. We can forget doing surgery, complex surgery, we can forget doing transplantation, we can forget giving chemotherapy, we can forget neonatal care because all the babies will die. That potentially could be the future. And if you don't believe me, go and visit some of the hospitals in Southern Asia or the Far East where they've got problems already. They've got major problems over there. So this is why it's really important for us. Okay, thanks for your input. Thank you.